A 22-year-old a 22-year-old man comes to the physician because of 3-day history of sore throat and difficulty of opening jaw. He has no history of serious illness and takes no medication. He is allergic to penicillin. His temperature is 101, pulse 120, respiration 20 per minute, blood pressure 100 by 70. There is cervical lymphadenopathy bilaterally. Examination of the throat shows deviation. Examination of the throat shows deviation of the uvula to the right, edema of the soft palate on the left, bilateral pharyngeal erythema with exudate. After the drainage of the abscess, which of the following is the most appropriate pharmacotherapy? Ready?
Oh, sphingomycin peritonsillar abscess describes the localized accumulation of fluids between the palatine tonsil and the pharyngeal muscles. It is potentially life-threatening condition because of the risk of local swelling and airway compromise. It is most common in adolescents, particularly those with a history of prior tonsillitis or pharyngitis. While the infection is often polymicrobial, gram-positive organisms such as strep and staph species are often predominant. Patients present with fever, severe neck pain, trismus, localized swelling and foot pains overlying the tonsil and may show signs of airway compromise such as muffled voice and drooling. The diagnosis is clinical but may be supported by radiography. The mainstay of treatment is nasal aspiration or incision and drainage of the tonsillar abscess, followed by antibiotic therapy, generally beta-lactams such as amoxicillin um, and aminopenicillin. And augmented aminopenicillin with beta-lactamase inhibitors like ampicillin sulfactam. However, patients allergic to penicillin may be treated with clindamycin, which provides broad-spectrum coverage from gram-positive, gram-negative. And anaerobic, not cephalexin. First generation cephalosporin that may be used for peritoneal abscess. However, because of cross-reactivity, some patients with penicillin also have allergies to cephalexin. Because of this, clindamycin is better. Next.
Is a 16-year-old boy who was diagnosed with HIV infection 1 year ago comes to the office for a follow-up examination. He has no history of opportunistic infections. Immunizations are up to date. His CD4 T lymphocyte count is 550 and plasma viral load is less than 1000 copies per ml, a hundredfold decrease since he began triple antiretroviral therapy a year ago. He and his girlfriend are sexually active and use condoms consistently. His plans for the summer includes traveling to Africa for 2 weeks on a medical missionary trip, buying a cat, joining a swim team, and obtaining a part-of job in a daycare center, which involves caring for toilet-trained toddlers. Evidence of which of the following activities is most likely to minimize his chances of opportunistic infection. Ready?
Oh, yeah. Cleaning the cat litter. You answering this question so fast. Have you done this MBME before?
Sorry?
You're answering this question so fast. I'm like, whoa. Right.
No, like I have solved this previously. Is
Okay, okay. So you kind of okay. Because I was like, this MBME just seems easy for you. Right. I'm like, you're answering them so fast. I'm like, wow. I was like, I know it's not super hard, but hey, it's like super easy for you. Okay, okay. You kind of like remember a
not
little bit.
that super easy,
I'm like,
but because when we summarize as a whole, then the number falls down.
hmm.
Like
Toxoplasma.
initially, the NVMe 14, like when we start, you seems that it is pretty easy, but in between, we lost plenty of questions.
Yeah, that's true. Toxoplasma gondii is intracellular protozoan parasite. Transmission can occur through the ingestion of oocysts from cat feces or infected meat, direct transmission between a mom and fetus, and from organ transplant, which leads to invasion followed by dissemination of the parasite where it typically lies dormant. Those patients should avoid cleaning the cat litter. Uh, T-gondii is ubiquitous organ and nearly 10% of video will be seropositive for it. But the parasite does not usually cause severe disease in immunocompetent people. However, patients with HIV and CD4 count less than 100, reactivation can occur with several distinct clinical syndromes, of which cerebral toxoplasmosis has the highest rate of morbidity. Cerebral toxoplasmosis typically presents with multiple ring-enhanced lesions scattered to the brain. Seizures, focal neurologic deficits, and systemic symptoms are common, as are signs of increased intracranial pressure. Patients with HIV infection and who test positive for T-gondii IgG antibodies are typically treated empirically with sulfonamide and pyrimethamine therapy if cerebral toxoplasmosis is suspected. The diagnosis is confirmed with brain biopsy. Cerebral toxoplasmosis is an age-defining disease. Yeah, I guess that's it.
Next, a 42-year-old woman, gravid to para 1, 12 weeks of gestation, gravid to para 1, 12 weeks of gestation, comes to the physician for her first prenatal visit. She conceived a dichorionic diamniotic twin gestation after in vitro fertilization. She has no history of serious illness and her only medication is prenatal vitamin. 2 years ago, her first pregnancy ended in cesarean delivery at 39 weeks of gestation because of a breech presentation. She is 165 centimeter, 5 feet 5 inch tall. She weighed 68 kg, 150 pound. Prior to the pregnancy, BMI is 25 kg per meter square. He She has had 2 kg weight gain during her pregnancy. Her blood pressure is 110 by 70. Examination of shows uterus consistent in size a 12 weeks of gestation. The patient is at great risk for which of the following complications? Dichoric. Ready?
Twin pregnancies are identified by ultrasound method characterized by chorionicity and amnioticity. Monochorionic and monoamniotic pregnancy generally associated with high risk of neonatal morbidity and mortality. Retained labor is the most common complication of twin pregnancy. The other common complication is intrauterine fetal restriction, fetal malpresentation, which while less common complication includes twin pregnancy, transfusion syndrome, fetal aneuploidy, and umbilical cord impairment. This patient is at greater risk for preterm labor, which occurs between 20 to 37 weeks of gestation with regular uterine contractions and cervical change. As preterm delivery is associated with high degree of fetal mortality and mortality, preterm labor is usually treated with oncolytic therapy, hydration, and bed rest. Steroids are also given to promote fetal lung maturation. If the gestational age is less than 34, ultimately the method of delivery depends on fetal well-being presentation. It's not E. Uterine rupture is a dangerous complication of pregnancy where the muscular wall of the uterus tears. Severe pain is a common initial finding. Hemodynamic instability can manifest in the mother with tachycardia and hypotension in the fetus with deceleration, tachycardia, bradycardia, or loss of beat to beta. These factors for uterine rupture include vaginal birth after C-section, multiparity, and induction of labor with prostaglandin analog and oxytocin. While this patient does have some risk factors for uterine rupture, preterm labor is still more common complication of twin pregnancy. Okay.
Next. On arrival to the post anesthesia care unit, 15 minutes after undergoing fourth and fifth metacarpophalangeal arthroplasty, a 32-year-old woman with rheumatoid arthritis has had finger stick blood glucose concentration of 350 mg per deciliter. During the induction of the anesthesia, endotracheal intubation was complicated by arthritic changes to cervical spine. Dexamethasone was administered to decrease the airway edema. She has received Ringer's solution during the 60-minute procedure. Intraoperative blood loss was minimal. Medications are prednisolone and methotrexate. She is awake. Vital signs are within normal limit. Cardiopulmonary examination showed no abnormal neurologic, no focal finding. Which of the following most likely cause a patient's hyperglycemia? Ready?
Moment between A and E. Examiners management during induction of anesthesia. Very careful stress. I know after operation you have high glucose. I don't know if it's that high. And then the examination during induction of anesthesia. You gave the examination to cortisol. Ah, I feel like it's A, but it can also be E. Induction of anesthesia. The thing was not working.
Sorry.
Okay, I feel like it's A.
You
A.
you
Damn it.
feel like A, but you have chosen E.
Because E just makes
Sorry.
because it just makes sense. Okay, whatever. It makes sense, but not for this question, but it just makes sense. Whatever. Sometimes they say just go with the answer that
Some
you know.
sometimes I don't understand that.
Whatever,
Like you listen, your brain is telling to do this, but you listen to your heart.
whatever. You don't
is
know,
it is it a love story? Like,
sometimes on they say people say on the exam, don't go with the answer that you never heard before. Just this is the answer you've seen before. Just pick that one.
but you
Don't
are
go with
making
the answer
sense. But you
you
have
know.
made sense for a reason. May
But,
be right, may not be right, but you made some of the reason, isn't it?
but
So
both of them
why?
that's what I'm saying. Both of them make sense. I know after operation there is an increase in glucose, but I don't think it's that high.
Yes,
So that's
true.
why this
Like
one makes
stress can cause hyperglycemia, even
yeah.
us also, isn't it? But
If you are
if we do a surgery, stress can
yeah,
cause slight
uh-huh,
hyperglycemia, but
uh-huh,
it does
uh-huh.
not cause 350 milligram per deciliter,
That's why I
isn't it?
was like, yeah. I mean, I don't know if it doesn't cause. I know it causes, but I didn't know how high it goes. That was my thing. And then I was like,
Dexamethasone is a very potent steroid.
yeah, the A just made sense because I was like, okay, he was on prednisone, which caused adrenal insufficiency. Then they gave for that, so it made sense. Oh, but I was like, it's not the answer you're familiar with. So why would you pick that if you're not familiar with that answer? Anyway, anyway, the administration of steroids such as dexamethasone will induce a transient hyperglycemia in patients. Steroid cause an increase in blood glucose concentration by stimulating the liver to release glucose. Some other effects of steroids are reduced inflammation, increased blood pressure as a result of vasoconstriction, um, increase due to fat and protein metabolism, and immune suppression. In patients without diabetes, this increased blood glucose concentration will subside quickly as the pancreas releases increased insulin to combat hypoglycemia. In patients with diabetes, care should be taken when choosing to use steroids as blood glucose concentration can remain high for a long time. In that diabetes, patients should be educated about this effect so that they can manage their medication diet appropriately. This patient presentation is a normal response to administration of steroid. And given the benign physical exam, there should not be any further concern or work. And it's not a normal perioperative stress response causing an increased blood glucose concentration is a reasonable diagnosis in this patient. Blood glucose levels do generally rise after surgery, with the onset varying from immediate post-operation to several days after. Had this patient not received dexamethasone, this will be the most likely cause. However, the acute increase caused by dexamethasone administration is the most likely cause. You see, so it can go up to 350,
Yeah,
but it's just that here because they specifically added this line of dexamethasone was given that
administered.
anyway. Those kind of questions. Next.
Hmm. We have to read all the line very carefully.
Yeah, that's why I say I hate those kind of questions because during the exam you're not gonna pay attention to each single line. Like it's like. But here, yeah, you have to read the line.
They they are changing these things too much because are now
Yeah,
people are very sensitized. Like
yeah,
they found the keyword and start choosing the answer.
yeah,
That's why they
yeah,
are changing this.
yeah. I mean, it makes sense because it's the same. That's the only thing they can do. It's not like you can add new material. I mean, even if you can add new material, it's
They
only
are
limited.
adding new material also.
But it's still limited. Like you can only add, there's a new drugs that are coming up or things like that. But some things are always going to be the same. Like the medication, like the bugs, the bacteria, what like it's just something
Yes,
that kind of always going to be. So the best thing is try to make it a little bit, try to eliminate those the words that you say, the keywords. So people don't, as soon as they see the keyword, oh, I already know the answer. It's this. So that's they have to try to modify the questions because there's only so much material you can. And it's 300 and some. How many questions on the exam? 300 and something. So there is only so much material you can ask. You cannot ask the whole medicine. You have to pick. So I mean, I understand it. It just sucks for us that have to take the exam. You know, if I
Yes,
knew that, if I knew that, I would have just tried to take that exam so many years. There are some things I wish I knew like years ago. Just try to take the exam the soonest before those changes start happening.
okay. 3 days after an operation, 3 days after an operation of aortic stenosis, 67-year-old white man is being evaluated by surgical team. A medical a medical student takes one of the patient. A medical student takes one of the two patient information charts hanging outside the room. While reading the chart, the patient realizes that the ethnicity listed on the chart does not match the ethnicity of the patient. Verification of the name of the chart shows the student had been taking the chart for other patient in the double room. Both charts are labeled room 4561 instead of chart for the window bed being labeled 4562. Individual members of the team laugh at mix-up, and resident states that the charts are often misnumbered due to patients shifting room. Which of the following is the best appropriate next step by senior members of this team?
Well,
Ready? Yes.
report the incident to Quality Assurance Committee for further analysis. System-based approach to error is rooted in an understanding that most errors occur due to
If
combination of
anything happens, they told the thing to the system. Is it like that? Is it hospital works like that?
the real word. I don't know.
Yes.
I don't know. I mean, I never had to report when I was doing my rotation. I never had to report
Like
anything.
this happens now. This happens by the interns, like not intentionally, but it happens. And if it happens, if they label wrong, they actually change this thing and correct that person. They need not to report to the committee and like that. Okay.
Yeah, probably in real life, yeah, they don't go all the way to report it. I know I did my rotations, and even if I see something wrong, I just continue. I don't say anything. But,
Yes.
yeah. I
Okay.
mean, because I also okay, fine. It also wasn't my place of where I'm only there for a few weeks doing my rotation. I'm not gonna come and create issues. That's kind of hard.
Yes. And you are not liable for any patient.
Yeah. Also, I mean, I guess that's not a good. I care if something happened to the patient, but I
No,
I
no.
just want, you know.
Like during round, every resident is tagged with every bed. Like a resident is
I get
liable
what
to that bed, and
I
they have
get what
to
you're
take all the history and medical examination to his senior, isn't it?
saying. Yeah, I think yeah, I get what you're saying. Okay, okay. Yeah, maybe if I was, yeah, I guess if you are a resident, you will want to report it because then it can follow you,
Yes.
right? But yeah, okay. Yeah. System-based approach to error is rooted in an understanding that most error of combination of human errors and system that is designed in such a way that allows error to occur. When an error occurs, root cause analysis in combination with system-based approach can allow for identification and the underlying factors that lead to human error. including environment, equipment, technology, communication, culture, personnel training, other human factors. The goal is to understand the underlying factors that allow the error to occur and to prevent similar errors from happening in the future. In this example, there are several environmental predispositions such as error occurring, including patients being frequently moved and charts being stored outside the share room in a shared location. There is also a broader cultural problem such that errors are not taken seriously. Finally, there are two human errors on the part of both the nurse and the intern in misleading and mislabeling and misreading the chart. It's important to understand that errors occur due to a variety of failures, and error prevention must address all of these failures. Hospital quality assurance committee have the expertise to conduct
Your battery.
the quality here this time. I don't know why I'm just whatever. Trying to change. You know, if I pass my step two, I'm buying my. This is gonna be my gift to myself. You know, if I pass, that's why I haven't changed it yet. Because I'm like, man, what's the point of me getting a new computer and
It's
I
not a problem.
you know? But if I pass my step, this is gonna be my gift to myself. Get a new computer, you deserve it.
After passing your step two, you can give a gift to Trump also.
I know. Oh my God, it's ridiculous. Hospital quality measure. Um, Hospital quality assurance committees have the expertise to conduct root cause analysis and address system-based failures that may lead to error. Okay, next.
Okay. A 42-year-old woman comes to the physician because of 1 month history of intermittent mild pain in her right lower abdomen. She has not had fever, chills, changes in the bowel habit, or urinary symptoms. 3 years ago, she underwent bilateral prophylactic mastectomy because her maternal grandmother, uh, mother, and two other sisters have a history of breast cancer. The patient has no history of serious illness, and her only medication is calcium supplement containing vitamin D. Her temperature is 37 pulse, 80 per minute, respiration 18 per minute, blood pressure 116 by 68, cardiopulmonary examination show no abnormal. The abdomen is soft and non-distended, and the liver is not enlarged. Examination of the right lower quadrant shows tenderness to the deep palpation. There are no signs of peritonitis on pelvic examination. A mass is palpated in the right adnexal region. No other abnormalities are noted. Pelvic ultrasonography shows an 8 into 6 complex multisepted right ovarian mass, and there is no ascites. Which of the following is the most appropriate next step?
Hmm. Got the algorithm for ovarian. Uh,
The mass is multisepted and very big mass, isn't it? So we should do what?
we,
We
I
should
don't think.
not do surgery
Okay, you should go straight to surgery. That's what you're
because
saying.
because the mass is bad, isn't it? Multisepted and very big mass.
I forgot the
And
algorithm. I don't think you
uh,
do final by you don't. I don't think you
yes,
do
we don't do fi-
biopsy for ovarian mass because we
yes,
can
we do not
both
do.
see
It is not the breast cancer, isn't it? Or thyroid thing. It,
huh?
it is not the breast cancer or thyroid thing that we do. We need to do the FNAC, fine needle.
Yeah, yeah, I don't think you do FNA on ovarian mass because
Yes, yes.
can spread. Yeah, probably not that. So we don't do the CA, the carcinoembryology to see
Oh,
we go straight to
it is insignificant, isn't it?
is insignificant. Okay. Yes, let's go straight to surgery.
Let's cut her.
Okay. Yeah, you're right. Let's go straight to surgery. Ovarian cancer most commonly presents with abdominal distension. She has abdominal, early satiety, weight loss in patients who are postmenopausal. Signs and symptoms of advanced disease may also include bowel obstruction with subsequent nausea, vomiting, ascites, pleural effusion, and venous thromboembolism. In addition to this, physical exam may show a palpable adnexal mass, as it did in this case, or lymphadenopathy. Ultrasound is recommended to identify or characterize the responsible lesion, with features including septations, cystic components, uh, that are the responsible lesion, septation, cystic components, blood flow, and heterogeneous structure. These factors for development of ovarian cancer include family history, BRCA, advanced age, smoking, nulliparity, radiation therapy. The diagnosis is confirmed through surgical excision of the lesion with treatment, in addition to surgery, including chemotherapy. This patient has an extensive family history of breast cancer in first degree relative, including BRCA, as well as large septate uh, ovarian mass on ultrasound, both of which are increasing for ovarian cancer. Okay. Therefore, the most appropriate next step is operative exploration and removal of the mass to diagnose ovarian cancer. Okay, so here, because she has the family history, you remove the mass
Genetic
to
modification.
diagnosis. It's not, you don't diagnose it first. You remove the mass and then you diagnose. Fine needle aspiration of the mass is not recommended for evaluation and diagnosis of suspected ovarian cancer. While it's most commonly used, what it is a commonly used technique in the evaluation of many masses, typically avoided in ovarian masses to prevent seeding. Makes sense. The most appropriate surgical treatment or confirmed ovarian cancer is hysterectomy with bilateral salpingorectomy. So even if they suspect, you just take out everything. Serum carcinoembryonic CA assay is also used in the evaluation of management of ovarian cancer, and non-specific mass may be more likely to be ovarian cancer in the setting of increased CA concentration. Initial concentration are also drawn once a diagnosis of ovarian cancer is made, and these concentrations are monitored during and after treatment to monitor for recurrence. However, this assay is not non-specific and will not confirm the diagnosis. But that's used if you don't know, that's when you use this.
These markers are actually good after surgery, isn't it?
Yeah, most of them it seems like it.
So in ovarian cancer, like in ovarian mass, we will do ultrasound first if it is an option. But surgery is a must.
It seems like it, like I would think you diagnose it first before going into like removing the whole thing, but
Yes.
it seems like you just remove the whole thing and then you diagnose the whole thing. But what if it wasn't cancer? Then you just remove the ovary of the person.
Yes, obviously. If it is an ovarian mass, like if it is benign also, we need to remove the mass.
Oh, you still remove it even if,
Yes, yes.
okay.
Like recently, one of my friend had
Mm-hmm.
torsion of the ovarian torsion. That was like very bad. She went to the hospital in a very toxic condition and immediately did her surgery, but she lost her ovary. Like she lost her right ovary. She had only one ovary because
Mm,
we what we have read that surgical detorsion, but the only detorsion is unable to detorsion cannot be
mm-hmm.
done on that setting. You got my point. That was so bad, so detorsion cannot be done. So okay,
Um, but is she okay? Like after
yes,
this? Okay.
yes, she is okay now. She had a baby also, so no,
Uh,
no worries.
wait, after the surgery, she had a baby?
No, 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 not after the surgery. Before the
Oh,
surgery, she had a baby.
oh,
She's planning to take another baby with the remaining ovary.
with the
Okay.
remaining ovary. Okay. Good. Okay.
Okay. A 28-year-old man comes to the emergency department because of 1 week history of increasingly right lower abdominal pain. During this time, she has had fever, nausea, vomiting. She has had chills. He has no history of serious illness and operative procedure takes no medication. Temperature is 38.3 pulse 100 per minute. Blood pressure 120 by 60 millimeter of mercury. Cardiopulmonary examination shows no abnormality. On abdominal examination, 6 into 8 centimeter tender mass is located. 6 into 8 tender mass is palpated in the right lower quadrant. There is no overlying erythema or induration. CT scan of the abdomen and pelvis shows 6 into 8 centimeter fluid collection with an enhancing rim of right lower quadrant. In addition to broad spectrum antibiotic therapy, which of the following is the most appropriate next step in the management?
Understand. I'm always between two answering these questions. I don't understand what is happening today.
He has fever.
I know it's. I'm thinking.
Is it abscess?
Oh,
Fever and mass.
I thought it was appendicitis, appendicial abscess.
Appendicular mass, appendicular abscess can happen.
So do we do the drainage or do we do straight to laparotomy?
I think that first drainage, then operation.
First drainage, then
I,
operation.
I don't know. What
I don't. That's what I'm saying. I'm between those. I don't know what's
I
happening.
think that if it is appendicular, if I am thinking right, if it is appendicular abscess, then first we need to do the draining first because it is without draining. If you want to do the operation, that would
Uh-huh.
be dangerous. Okay, let's see.
Let's see. Yeah, it's the drainage. Appendicitis classically presents with right lower quadrant pain that is often periumbilical onset and with associated nausea, anorexia, fever, leukocytosis. Hypertrophy point sensitive location for tenderness and palpation is located two-thirds the distance between the umbilicus and inguinal ligament, as this is the common position of the appendix. Diagnosis is facilitated by CT, MRI, and ultrasound, which may show appendiceal enlargement, the presence of appendicolite, appendiceal wall thickness, periappendiceal fluid, straining. In cases of perforated or ruptured appendicitis, an abscess can form. Treatment of appendicitis is with laparoscopic appendectomy to prevent complications such as appendiceal rupture, sepsis, and death. Cases of stable patient with perforated appendicitis with associated abscess, IV antibiotics, and percutaneous drainage is preferred as there is a shorter length of hospital stay and fewer complications than with immediate operative intervention. In addition, percutaneous drainage may allow for inflammation to decrease in the area prior to appendectomy, which may negate the need for extended bowel resection. In this scenario, hemodynamic stable patient, the next step is management of percutaneous. Let's see, rectal apparatomy may be indicated in cases of rupture of perforated appendicitis in the hemodynamically unstable patient. In this scenario, the patient presents with increased pulse and Temperature but has a stable blood pressure. Percutaneous drainage would be appropriate. Next step, management to allow for drainage of the fluid collection and resolution of inflammation in the region prior to perforating appendectomy.
Next, a 77-year-old a 77-year-old woman comes to the emergency department after 1 hour comes to the emergency department 1 hour after the sudden onset pain and numbness and stiffness of her right forearm and hand. She has hypertension and atrial fibrillation. He has myocardial infarction 2 years ago. His medications are metoprolol, lisinopril, warfarin. His medications are metoprolol, lisinopril, and warfarin. Our temperature is 36.8 degrees Celsius. Pulse is 60 per minute, and irregular respiration are 14 per minute. Blood pressure 140 by 90 millimeter mercury. Cardiopulmonary examination show no abnormality. The right forearm and hand are pale and cool with a capillary refill of 8 seconds. Pulses are absent in the distal aspect of the pulses are absent on the distal aspect of the right lower extremity. Mm, the right axillary pulse and the pulses of the left upper extremity within normal limit. ECG show atrial fibrillation and ventricular rate 72 per minute. There are no acute changes. Hemoglobin 12.3, hematocrit 37%, leukocyte 10,500, platelet count 3 lakh 15,000, PTT 27%. She is scheduled for embolectomy in 19 minutes. Which of the following is the most appropriate next step?
Ready?
Yes.
Giving additional heparin to the medication regimen. This patient with acute onset severe arm pain, pallor, and pulselessness in the setting of subtherapeutic INR or subtherapeutic. Okay. As presentations suggestive of acute critical limb ischemia, thromboembolic event can cause critical limb ischemia in patients with otherwise erratic normal. Peripheral vasculitis, the most common cause of embolitis of the lower extremity is the heart, related to a variety of underlying pathology, such as AFib in this patient. Although she's on anticoagulation, her INR is subtherapeutic, making her at risk of developing cardiac thrombus. How do they know the INR is subtherapeutic? I thought 1.5 was the normal. Anyway, symptoms of thromboembolic event of the extremity include acute pain, swelling, pallor, responsiveness. Manifestation include muscle and nerve death with severe pain and possible compartment syndrome. If acute limb ischemia is suspected, vascular surgery should be consulted immediately, and a heparin drip should be started while awaiting definitive management with thrombectomy. I
Ready?
understand. I thought
Sorry.
the INR was I thought the INR was normal here. It's not.
Uh, like why you are thinking
You see
INR?
here,
Yes.
it says the anti she's on the INR is still subtherapeutic
Yes,
range. Maybe,
INR should be within 2 to 3. We
oh, I
we need
thought,
sorry. Yes.
I thought it was
In
supposed to be
atrial
funny.
fibrillation, I think that INR level should be raised,
Oh, okay. Mm.
and that's why for effect for helping the anticoagulation. Hmm, sorry. What?
You got it. I get
Yes,
what you're saying. Yeah, you're right. Okay, got it. It's 10.5 for normal, 1.5 normal people and 2 to 3 for IMS. Okay, next.
a 45-year-old a 45-year-old woman comes to the physician requesting a second opinion of a recent diagnosis of the multiple sclerosis. She had smoked one bag of cigarettes for 25 years and asks if cigarette smoking contributed to the current condition. The physician finds a recently published study evaluating the relationship between cigarette smoking and MS. A total 100,000 women between age 18 to 40 were polled about their medical and the social history over 10-year period. Data showed 250 patients were reported developing MS. The rates of the cigarette smoking in patients with MS were the compared with those 6-15 age and location matched participant without MS. Which of the following is the best described study design? Ready?
One moment. I can get the woman based on MS and not MS. And then they asked them if they they ever smoke. Oh, between case control and cross sectional, they asked them. Okay, fine. Go with it. Feel like it's cross sectional. Okay, ready. Case control. It's very nice. Not section. This study compares one group of patient cases with outcome on the study multiple sclerosis. So, group of patients with multiple sclerosis is the outcome against a second group of controls, so people without the outcome, without multiple sclerosis, and then identifies the associated exposure, which is like smoking. This study design is known as case control study. Case control studies can be conducted in a prospective or retrospective manner. There are always observational by grouping patients by outcome and comparing difference in the odds of exposure. Case control can detect associations between exposure and outcome, such as exposure to smoking, an outcome of developing MS. This is described statistically as odds ratio. Two unrelated variables, we have OR of 1, whereas positive association between exposure and outcome will have OR greater than 1, and negative associated variable will have a OR less than 1. Case control study are therefore capable of establishing association between exposure and outcome, but they did not establish causality. A cross-sectional study examines a sample population at a single point in time and describes the prevalence of a particular disease mm, or a risk factor. Okay. In contrast to cohort studies, which group patients according to exposure, and case control studies, which group patients according to the outcome, Perceptual studies analyze both disease states and exposure simultaneously. In this example, patients are grouped according to disease outcome status, which is not consistent with perceptual study. Okay.
Next, can you tell me which one is the answer?
Oh,
You don't need
because
to read anything. This patient has atrial fibrillation and you want to give digoxin. So how you will write oral digoxin in a prescription?
not this, probably not this, trailing zero, not this, doesn't have a zero. Q, QD, I don't know what that means. Probably this one. Is it microgram? No, this one has a trailing zero, no, not that one. Probably for this one. Between those two.
Uh, should not in the prescription. We should read everything in a clear manner. Okay.
Did they say, because here the only difference between those two is like the microgram and the mg.
Milligram, yes. Milligram is
Uh,
easily understood by the people than the microgram, isn't it?
and it's easily. Oh, okay. Okay, so I guess it will be this one. But the trail is zero. Okay, I guess it will be this one. Yes, I'll go with that.
Ready?
Wait, did I choose the? Okay, yeah. The appropriate writing of prescriptions and orders is crucial for accurate delivery of care and for patient safety. In many settings, the use and design of electronic medical records has been designed to minimize the opportunity for prescriber errors. Okay.
Sorry.
However, However, in many other settings, including scenario, orders may need to be entered manually by the physician or written by hand. Orders must be written clearly and unambiguously. When writing by hand, special attention must be paid to legibility. A variety of common errors and pitfalls have encountered in have are encountered in order writing. The placement and eligibility of decimal points is a common problem and can lead to dangerous overdosing or underdosing. Decimal points should be unmistakable and should be avoided when they are not necessary. Units should be ambiguous and written out fully when necessary to avoid confusion. Both MCG and UG can be mistaken for MG and should be avoided. Oh, really? Of the choices given, digoxin, blah, 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 is the most clear. Wait, it's not, what was my other thing? B. Digoxin 1 micro blah, 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 daily are both incorrect. It's important to write orders in an unmistakable way and to anticipate the way in which an order can be misread. In both choices A and B, the use of micrograms should be avoided because it can easily be misread as NG, resulting in a thing called writing out micrograms is a better alternative. Okay. Additionally, and oh, got it. So don't use micrograms, I guess. Next.
Let's take a 5 minute break, please.
Yeah, sure.
Okay. A 37-year-old woman comes to the emergency department 12 hours after the onset of severe epigastric pain that radiates to the back. 2 weeks ago, abdominal ultrasonography showed gallstones. She began low-fat diet. She has no other history of serious illness. On arrival, her temperature is 100, pulse is 130 per minute, respiration 28 per minute, shallow, blood pressure 95/65, Abdominal examination showed distension and ecchymosis of her periumbilical area. There is diffuse severe tenderness of all quadrids. Vital bowel sounds are absent. Serum studies show total bilirubin concentration 1, amylase 1400, lipase 950. Which of the following is the most appropriate next step? Ready?
Ready?
Yes.
CT scan of the abdomen, what's happening today. CT scan of abdomen with contrast. The patient increased activity of lipase amylase in setting of epigastric pain and history of gallstone, acute pancreatitis carried. While there are numerous causes of acute, the most common non-traumatic cause is gallstone and heavy aqueous consumption. Gallstones form in the setting of lithogenic bile and may subsequently pass out of the gallbladder to the cystic duct and eventually reach the common bile duct. The main pancreatic duct also connects to the distal common bile duct, which is a conduit for pancreatic enzyme to reach the duodenum. If gallstones become large in the distal aspect of the common bile duct, obstruction of pancreatic duct can lead to release and activation of pancreatic enzymes within the pancreas, which causes substantial inflammation and pain. Additionally, as the flow of fat toward the duodenum is obstructed, patients can develop hyperbilirubinemia and increased liver enzymes. This kind of the abdomen with contrast is often performed as diagnostic step to evaluate for pancreatitis or other underlying cause of abdominal pain. Treatment of gallstone pancreatitis is either with cholecystectomy or intraoperative cholangiography, or in most cases with ERCP to retrieve the obstructing gallstone while awaiting procedural intervention. Patients should be treated with IV fluids, pain medication, antibiotics if there is suspicion of biliary infection. This patient most likely has acute pancreatitis. The most common step is CT scan of the abdomen to the CT scan of the abdomen. It's not ERCP, but it's anatomy and patency of the biliary tree through endoscopic canalization of the duodenal papilla. ERCP is indicated in evaluation of acute and chronic biliary pathology, but it serves as both diagnostic and therapeutic purpose for conditions such as cholecystectomy, biliary leak, and gallstone pancreatitis. In the case of suspected acute pancreatitis, the most appropriate next step in diagnosis is CT scan of the abdomen with contrast. I don't understand. Because here we already knew it was gallstone pancreatitis. We know it was acute pancreatitis caused by gallstone pancreatitis. We can tell it from the question. So why don't we go straight to ERCP? We know it's a gallstone that's causing it. Omar,
Yes. I'm
okay.
thinking like two even if thinking this way, 2 weeks ago there is like abdominal ultrasound done, isn't it? 2 weeks ago,
Okay,
and
okay,
then after two in these 2 weeks he is pain free, isn't it? If it is not like he is carrying the pain for 2 weeks, then he came to the hospital. It is not
okay,
like that, isn't it?
okay, okay. Uh-huh, uh-huh.
So her her what can I say? If if like her thinking this way, like you have sudden severe abdominal pain and we do ultrasonography and we found that there is gallstone along with the serum amylase is lipase is high, then
Mhm.
you need you don't need the CT scan of the abdomen. You got my point. But
Okay, repeat it. You have pain and then they do
like I have a pain,
uh-huh.
so I go to the hospital and it looked like gallstone pain in the like gallstone pain.
They don't do imaging. They just or
Th-
they do imaging.
yes, 2 weeks ago they do imaging, abdominal ultrasound show gallstone.
No, I'm saying the example that you're saying right
Yes,
now. If you go to the hospital, whatever you are in pain, they do imaging.
they do imaging, and they
Uh-huh.
found that there is gallstone.
Uh-huh.
And as they found the cause, so they do not do the further evaluation. They give antibiotic and and painkiller, and then my pain release, and I go to home. Then after 2 weeks I again came to the problem. I came to the sudden severe pain radiating to the back. Now, even if you think that it may be due to gallstone, but there may be another thing also. Because if it is gallstone pancreatitis, at that time, even if you give the painkiller, it will not, like pancreatitis is a very severe and devastating pain, and it will not just relieve by taking the low fat diet. In this stem, they said that abdominal ultrasonography should begin low fat diet, isn't it?
Okay. Okay.
My thought is that the even if the gallstone is one of the cause of the pancreatitis, in pancreatitis there is plenty of cause. Like ERCP can cause pancreatitis too.
Okay. So,
So we need to see the other cause also. For that, we need to do
yeah.
CT scan of the abdomen with contrast. That there may be other pathology, there may be pancreatic calcification or pancreatic necrosis or ascites. This may be present also. Maybe
I wonder if there is a like a because I thought okay, if I wasn't sure
if
I would
if,
have
if it is, if the like if the patient has pain now, and now he has done serum amylase lipase, so that is gallstone pancreatitis. So go, you don't need to do the CT scan of the abdomen with pancreas.
Mhm.
But if as it the ultrasound is done 2 weeks before, that's why they actually do another imaging. That is another thing, like that is another way of thinking.
Okay. Okay. So I was wondering if there is an algorithm for pancreatitis. But here you see it says that pancreatitis you just need two of the three.
Yes,
So they already gave us the pain radiated to the back.
back, yes,
They gave us the amylase and lipase. So we
yes,
don't really need the imaging.
yes, you don't need the imaging for
So that's what
diagnosing uh, pancreatitis. But
I said. But
yes,
here you see here it says the imaging modality is most useful for diagnosing, but if lab testing is unclear, that's when you do the contrast enhanced CT scan. So that's what I thought that here it was pretty clear that it was gallstone. So that's what I just went with yes. But I guess okay, okay, I'll just always
but
try to.
another thing in this stem, they said that bowel sound is absent. They have severe tenderness in our
Uh-huh,
stem, in the question. Bowel
uh-huh,
sound is absent. A bowel sound is absent. Absent bowel
uh-huh.
sound can be found on perforation also, isn't it?
Okay, okay.
So pancreatitis has plenty of complication, like complication within the pancreas
Mhm.
and outside the pancreas. Like pancreatitis can cause pancreatic ascites, it can cause pancreatic pleural effusion, pancreatic necrosis. You got my point.
Okay. I think I get what you said, like what
but
you're saying.
but it is very complicated. I know what I am talking about now, seeing this stem, but it is very hard to differentiate in the
No,
exam.
I think it's what you said, the way you explained it first. Like, yes, it showed gallstone 2 weeks ago. Then they gave
Yes,
him the medication or whatever, the
yes,
treatment, whatever for gallstone. So now he's coming back again with the pain. So we cannot assume that it was the
it
same
was
pain
same thing. Yes, it
as two
may
weeks
not,
ago.
it may be different issue.
It may be the okay. Okay. Yes. Wow. This block is weird. Okay. Yes.
And another thing,
Mhm.
like in this stem,
Mhm.
2 weeks ago, if the features of the pain looks like pancreatitis, they must do the amylase lipase, isn't it?
Yes.
And if that amylase lipase is negative, that means it is a new generation of pancreatitis. You got my point.
Okay, okay, I get what you're saying. I get what you're saying.
Like in our country, what we actually do in our country, like if the pain looks like pancreatitis or cholecystitis, we do imaging like ultrasonogram along with amylase lipase, because you don't know that the pain, the characteristic of the pain, what the patient,
Mm-hmm.
suppose you found that the Murphy's point is tender, but it may be pancreatitis also, isn't it? You don't
Yeah.
know the enzyme level, so we actually give the amylase lipase to confirm. You
Mm,
got my point?
got it.
Yes. Okay, can you give me 2 minutes? Hello, yes. Okay, next. A 72-year-old woman, a 72-year-old woman comes to the physician because of 3-month history of progressive shortness of breath with exertion of non-productive cough. She has systemic sclerosis, scleroderma, lesion of pale prednisone. Her temperature is normal, pulse 90, respiration 18, blood pressure 130 by 80. Examination shows tight visual skin, telangiectasia. There is thick taut skin over the finger. Bilateral basilar crackles are heard on cardiac examination. Right ventricular heave is palpated in the at the left sternal border. There is where is a grade 2 by 6 ejection systolic murmur, hard at best, fixed, split S2, S3 gallop. ACG shows which of the following is the most likely diagnosis. Um, Heart failure. Look at the ECG. Can
Oh,
you find some abnormality? Look at the P wave. Is it normal? Just P wave, nothing else. You don't need to see anything.
uh, no, it's not normal, but I don't know what. No,
P, yes, yes. If you find P wave is half of this small square, isn't it?
half of this month square. Okay.
Okay. And P wave looks like the bull's, what can I say? The bull's head, the bull's,
So what?
in the head, what is present in the bull? Bull. You have
The,
seen, you have seen,
no,
you have seen the bull fight?
bull
Bull,
fight.
yes. Yes. Bull fight.
No. Okay.
You haven't
I,
seen the bull fight. It is very
no,
famous
what
in
is
the
that?
Portugal. Bull's
Oh,
fight. Yes.
okay, 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 okay.
Yes,
Got
the
it.
uh, what the matador and the bull, the what is called the thing,
What?
they actually
What?
give you the pointed thing.
What? Like here?
No,
Oh,
no,
this
yeah,
the
yes,
horns.
yes, sorry, the
Okay, the horns. Uh huh.
okay, okay, look, now look at the ECG. It looks like the horn, isn't it? And it is, so if you find a P wave, it is more than 2.5 small square, it is P peaked, that means P pulmonally. That is the ECG finding in here. Sorry for this lots of things.
Yeah. It's
So
okay.
P peaked means P pulmonally. P wave has two patterns. If P wave is elevated like vertically, then vertically more than 2.5 millimeters small square, it is P peaked, P pulmonally. And if P wave is more than 2.5 millimeter horizontally, then it is P mitrally. So P wave has two pathology like P pulmonally and P mitrally. Okay. It maybe you seem like it is a complex topic, but if you know this thing, that would be easier to find out this
Yeah, in here in this
in
question because
yes,
they gave the ECG.
yes. Because
Um,
have you found any clue in this question after reading
I
this?
was no, I was between C, D, and E. I knew it wasn't A and B for sure.
But it
But
is B.
I couldn't pick. Oh,
The
it's
answer
B.
is B. Yes.
B as
Because
in cord hormonal.
yes, it is B is a
Oh,
corpulmonal. Because I have seen the ECG, and ECG P peaked means P pulmonary. Write the P pulmonally and look at the ECG
right. It's P
in the
hormonal.
Google.
This was this. Oh,
This
okay. You
ECG
said
you are very tough to understand, but if you write P peaked and P pulmonary, write P peaked pulmonally. Yes, the third ECG. Look at the third ECG. Yes, this one.
this.
Yes, this one. The
What is
yes, see this 2.5 millimeter. If the P wave is elevated more than 2.5 millimeter, it is P pulmonally. You got my point. Normally, it is less than 1.5 millimeter.
mm, mm. But here they don't have the bullhorn thingy that you
No,
said.
no, I,
Oh,
I am, uh, I made an example to make you understand that it seems
okay.
like a bull's horn, the P picked one. Look at this one. It looks like the bull's horn, the right one.
Okay. Okay. This one.
This one is normal.
Oh,
This one is like, sorry, in the limb lead it is more than 2.5 millimeter. In the chest lead like V1 it is 1.5 millimeter. But usually you will understand just looking at the limb lead like lead 1 to 3. This one,
yeah.
look at the this ECG.
Mhm.
This is P pulmonally. And if you
Yeah.
found P pulmonally, that means cor pulmonally, the number
Oh,
one cause.
Jesus Christ. You like cardio, huh?
Sorry.
You like cardio.
Okay, let's
Oh.
study.
Like I said, like you like cardiology.
Oh, okay.
Yeah. Yes. The fact that you understand those things, me, I just some when I see a question like that, and I'm like, okay, there is no way. I just
No,
pick
no,
the figure.
I am trying to make you understand the simple point that
Yes,
can
yeah,
be remembered in the exam.
yeah,
I'm not trying to teach you the ECG because if you start seeing the all the leads, then you will
yes.
not, then you will just waste your time.
I didn't even look at it. I didn't even look at
Because
the
why I talked so much in this regard, because if you don't read in this, if you don't see the ECG, you will be at a loss because CD is not the answer,
Yeah, yeah,
and you will just like exclude the very important option of the B,
yeah.
because they said that fixed split S2,
Let's
what
do
you will see ASD, isn't it? We will
ASD.
look
Yeah,
for ASD, but there is
yeah,
no ASD.
yeah, yeah. That's true.
And S3 gallop is the feature of the heart failure.
Yeah.
So you are not you can't find out the answer just looking at the question stem.
Yep.
Okay, let's
Okay. Give
study
me
the
the.
explanation.
it's called pulmonary. This patient with dyspnea, dry cough, right ventricular hip ECG showing multifocal atrial tachycardia, has presentation to the pulmonary. Pulmonary describes right heart failure secondary to chronic pulmonary pathology with increased pulmonary vascular resistance in right side of the heart failure. Can result from pulmonary pathology and increased pulmonary vascular resistance, example of which, but are not limited to COPD, interstitial lung disease, thromboembolic disease, systemic. That was the key. Primary pulmonary hypertension, if untreated, the persistent increase in pulmonary vascular resistance will result in right heart failure, which presents with jugular venous distension, peripheral edema, right ventricular hypertrophy, hepatomegaly, and with ascites. Treatment involves addressing the underlying cause, which in this patient is scleroderma. That was the cause. Okay, it's not. What was that? Also, cardiac exam would disclose crescendo de crescendo pulsus parvus that because of increased afterload from obstruction of the valve, left ventricular hypertrophy and diastolic dysfunction can occur. Patients may present with signs of left-sided heart failure, such as fatigue, shortness of breath, cough, dyspnea, and pulmonary edema. Stenosis is not associated with systemic sclerosis. Mm. In this patient, presentation is more consistent with right heart failure. Pulmonary edema. No, I knew it wasn't that pulmonary. Yeah, I guess. Pulmonary edema may be associated with a number of conditions, including left-sided heart failure. Patients with left-sided heart failure experience increased backflow through pulmonary vascular, resulting in increased pulmonary pressure and resulting pulmonary edema. This presents as dyspnea, autopnea, and dry cough. The presence of multifocal arterial tachycardia on ECG in the setting of this patient systemic sclerosis makes chronic pulmonary pathology highly likely. With chronic pulmonary pathology, right ventricular event or other symptoms of pulmonary is the most likely diagnosis. And VSD refers to, it makes sense, VSD. In interventricular, most commonly the membrane is characterized by a systolic movement best that initially left to right shunt, but if untreated, it can reverse. Patients may develop isomanger secondary to prolonged pulmonary vasculature remodeling the pulmonary artery and causing hypertension and shunt reversal. PSD will not present with multifocal atrial tachycardia on ECG. Does not cause systolic ejection movement. Okay, got it. Got it. Next,
A 16-year-old girl is brought to the physician by her mother. A 16-year-old girl brought to the physician by her mother she has not she has not yet had menstrual period. She has no history of serious illness, takes no medication. Her immunizations are up to date. She does not appear to be in acute distress. She is at 75 percentile for height, 80 percentile for weight, 55 percentile for BMI, breast, and PV. Here examination shows maturity rating stage 1. Pelvic examination shows 76 per mil international prolactin is 30. Which of the following is the most appropriate next step in the diagnosis? Mm,
right here. Okay, 13 to 9. And then FSH is 76.
FSH is high, isn't it?
Premenopause.
TSH is normal.
FSH. Okay, I don't know because I don't know if I'm looking at the premenopause or the mid cycle. Oh no, she doesn't have a menstrual period.
Menstrual
Pre-
period.
So it's high. So it's the only thing that's abnormal. Okay, what is the pelvic exam was fine. Mhm. And then FHS is high, but everything else is normal.
Ready?
One moment. She's 16. She already passed that thing. Estradiol. Mm, my brain is not working today. Stereotype analysis. Wait, hold on.
Is significant.
No, today, like my brain also is not working, so you're fine. Oh, wait, I was reading the answer, right?
Yes,
Yes.
yes, yes.
The most appropriate next step in diagnosis of this patient is karyotype analysis. Turner syndrome is a common cause of primary amenorrhea, which is secondary to ovarian dysgenesis. In the setting of 45XO genotype, other signs of Turner include short-stature cystic hygroma, wet neck, swelling in the hands and feet, coarctation or aorta, bicuspid aortic valve, horseshoe kidney, infertility. Additionally, patients with decreased estrogen concentration fail to develop secondary sexual characteristics like breast and underdeveloped uterus. Vital signs are normal. Diagnosis is made to carry type analysis. Other lab studies that may aid in diagnosis are increased FSH and LH. Turner syndrome management adolescent commonly involves monitor cardiac complication, growth hormone replacement, estrogen replacement for secondary sexual
In
characteristics.
this question, what they have given, they haven't given anything like short stature, wave neck.
Mm,
Where is that? Like
mm,
16-year-old woman without having menstrual period, it is significant, but we will not think about the turners at very fast reason, isn't it?
are very fast. Yeah, I got that wrong. That's true. I guess fine. That's one of the first things you kind of need. Oh, breast and pubic hair development, everything is then stage one. I guess, yeah,
This
that's
is
the
this
first.
is one of the key point.
Yeah.
But
And then the
FSH is LH is high.
FSH is high, everything else is normal. So yeah, I guess standard will be the first thing that you should think. I picked serum estradiol, but it doesn't. They're saying that serum estradiol, I guess that would be for ovarian insufficiency, and
Okay.
then for ovarian insufficiency, you need to have had already you have periods, and then you stop having period because you have ovarian insufficiency. But this person never had period before, so it's not that.
Yes.
And all the other questions, all the other answers don't make sense. Okay, maybe the medroxyprogesterone, the progesterone challenge, but that's for secondary amenorrhea. That's not for primary. Here is primary. So I guess yeah, karyotype will be the only thing that makes
And
sense.
in Turner, FSH LH is high, estrogen
It's
androgen
high,
is low.
it's low. Here they didn't give you estrogen and androgen. I think that's why I chose estrogen because I was like they didn't give it, but you don't really need it, I guess. Yeah.
But they are actually excluding the important clinical feature like the key clinical feature wave neck, shield chest, the
Yeah. But
cardiac
the,
problem.
in this question, if they gave you that, this is it will be so easy. Like you already know what, what to pick. Like they have to make it a little bit challenging because if they gave you the web neck and all, you already know. Like nobody can get it wrong.
Okay,
But yeah, okay. I guess just keep in mind primary amenorrhea. First thing you need to think about is Turner. I guess.
okay.
Yeah. Next.
In a recent study of Americans, the following data were presented. Native mortality rate is 2.2, African 1.2, Caucasian zero point 0.8, and Asian zero point 0.1. The authors concluded that in the USA, a greater number of Native Americans died of injury sustained from firearms than did the Caucasian American. Which of the following is the most accurate interpretation of the author's conclusion?
Okay. Jesus Christ. Occasion. Today is not
Ready?
a good day.
We
It
have done the same
is
mistake.
Jesus Christ. Incorrect based on concludes to this block. I don't know if it's today or the block that is hard. Incorrect because the conclusion is based on rates and not.
This block is very hard, truly.
Yeah, I don't know if it's the block or if it's me, but I'm
No, no,
like,
no. Look at this question. They have written nothing.
yeah, I'm like, what is happening today? Correct interpretation of statistical data is important both when conducting research and when applying research data clinically. Epidemiologic data is clinical research. Epidemiologic data in clinical research is often presented as a rate per unit of population. Rates are often used to describe incidence, which is the number of new cases expressed as a percentage of the total population at risk over a specific period of time. When presented as rate, the absolute number of cases is therefore dependent on the size of the population in question. In the given example, while Latin American had higher rate mortality per 100,000 people, the overall Native American population is much smaller than that of the Caucasian population. Given the current composition of the US population, it's very likely that the author's conclusion is incorrect. It's important to be aware of other methods of describing incidents, such as person time rate, example, number of incident event divided by the number of years each individual was observed added for all individuals. Or incident risk, number of incident events divided by number of individuals, multiplied by 100 to be expressed as a percentage. Jesus Christ. Okay. So the rate is affected by the size of the population. How are you supposed to know that the Native American population is smaller than the? I guess if you live in the US, you're supposed to know. Anyway, it's not B. I was between C and D and E. Incorrect because the conclusion is not adjusted for socioeconomic factors or urban rural difference are also not accurate conclusions. While other social, economic, and geographic factors may influence epidemiology, these factors do not influence the most important problem with author's conclusion, which is the disparity between size of the populations of the groups under study. Okay. Yeah, I guess here you just were supposed to know that the rate, when they're talking about the rate, the size of the population matters. Next.
An 8-year-old girl with ADHD is brought to the office by her mother for a well child examination. The mother says that her daughter has been greatly healthy. Her daughter has been generally healthy and has been doing well in school since beginning long-term methylphenidate therapy 2 years ago. The mother is concerned about her daughter having to take medication for an extended period of time. Medical history is otherwise unremarkable. She takes no other medication. The patient is at 25 percentile for height and weight. Vital signs are normal. Physical examination discloses no abnormality. Which of the following is the most appropriate response to the mother regarding the patient's need for medication?
Oh my God, what is happening today?
It is not your fault, truly. This
I swear, I don't know what is.
this question is look
I'm between A
look
and D. I don't know
just
why I keep.
just think if this block came at a first block in our exam, what will happen?
Oh my God, I'll be like, okay, yeah, I felt this. There is no point of continuing the exam. Just
Yes,
yeah,
yes, we will
just tell
surrender
me.
at after this block.
Abi just fail me. That's it. I don't need to be continuing this because I don't know what is happening. I'm between two answers in everything. Like I don't know. Okay, let's pick something. Ready?
Okay.
Oh my god. Okay. The current medication regimen will likely continue to benefit in adulthood. Patients with ADHD exhibit chronic symptoms of hyperactivity, impulsivity, inattention that occur in more than one setting and impair academic, social, and emotional function. Symptoms typically start in childhood. Children with predominantly hyperactive symptoms are unable to sit still and have difficulty taking turns. This is dysregulated dopamine, whereas children with predominant inattentive symptoms tend to daydream, process information slowly, difficulty in completing tasks. This is due to norepinephrine issues. The prognosis of children with ADHD is bad as it has been shown that only 10% to 20% of children with condition experience symptom remission in adulthood, so not a lot. Stimulants which include amphetamine and methylphenidate are first-line treatment that increase synaptic dopamine and norepinephrine. Many children continue to respond well to the same medication at the same dose as they transition into adulthood. Okay, okay. Next.
A 68-year-old man comes to the emergency department because of 1 week history of severe low back pain that worsens with movement. He has 2 month history of fatigue, decreased appetite, resulting in a 7 kg weight loss. He has he has not had he has not had fever, night sweat, bowel incontinence, urinary retention, or weakness. He has hypertension treated with hydrochlorothiazide, smoked 1 pack of cigarettes daily for 30 years. But quit 20 years ago. He does not drink alcohol or illicit drugs. He is 5 feet 10 inch tall, weight is 77 kg, BMI 24 kg per meter square. Vital signs are within normal limits. Pulse oximeter on room air show oxygen saturation 99%. There is tenderness to palpation L2 to L4. Muscle strength is 5 by 5 in the lower extremity. Deep tendon reflex are normal at the knees and ankles. There is no clonus. Rectal tone is normal. The remainder of the examination shows no abnormality. Hemoglobin 11.2, serum urea nitrogen 54, creatinine 2.1, protein 7.8, albumin 3.2, LB 67. Which of the following is the most appropriate next step in the evaluation?
Low back pain moves with movement, reflexes are fine, and smoke, appetite, no fever, no exercise. Okay, serum, urine protein, maybe crab symptoms, no crab symptoms. Oh, maybe renal, anemia, one thing, maybe. PTH, serum PTH concentration. Ah, that's PSA. No, nothing about PSA really here.
Ready?
CT, the chest. Oh my God, what is happening to me today? Okay, ready. Okay. Okay, so I guess the crab symptoms they don't always have to include the hypercalcemia.
Yes.
Oh Jesus! This patient presenting findings of bone pain, anemia, kidney dysfunction are consistent with multiple myeloma, malignancy caused by neoplastic proliferation of plasma cell. Plasma cell will produce monoclonal immunoglobulin light or heavy chains. which may result in kidney injury. Patients commonly present with constitutional symptoms of like fatigue, weight loss, lytic condition, and splenomegaly, symptoms of hypercalcemia like abdominal cramping, kidney stone, site disturbance, symptoms of anemia like pallor, dyspnea, and exertion, or with opportunistic infection secondary to immune dysfunction. Further workup is recommended with a complete blood count, CMP urinalysis, serum and urine protein electrophoresis, and imaging to determine the extent of malignancy. Peripheral plasmic acid shows red blood cell aggregation and neural formation. The diagnosis is confirmed with bone marrow biopsy. It is not, what was I? B. MRI of the spine also could help with identification associated with multiple myeloma, but it would not offer confirmation. Okay. And then what it thought, oh, renal ultrasound is not routinely performed in the workup of multiple myeloma while there is kidney damage from excess protein. Imagine finding on ultrasound would not assist in confirmation. Cortical thinning of whatever may be noted on imaging, but proteinuria and resulting kidney injury are best evaluated with lab studies. If there was concern for obstruction or structural pathology, ultrasound may offer information, but it's not part of the field work. Okay, next.
Okay, one question.
Yes.
Like if beta ECG is high, inhibin is high, and estriol is low, and alpha fetoprotein is low, what is your diagnosis? Like, is it Downs, Turner, or is it Patau, or is it Edward?
You gave me a thing for that. It was high up. Wait.
Yes,
You
you
gave
are
me
in the
the
right track.
you gave me the money for that. What was it?
High up,
High
Down
up.
syndrome. Yes.
Yeah, that was dancing. So it was high.
Beta ECG and inhibin, if it is high, that is Down
Yeah,
syndrome. Okay, now it is not the question. I am now
it's your
you
question. Sorry.
you found a woman who
Mm,
is at like 7 or 8 weeks of pregnancy, and she is
okay.
concerned about uh, that her baby may have Down syndrome. Then what you will do next?
Seven.
Like,
You said 7 or 8 weeks.
yes, 8 weeks of gestation. Like, or suppose, okay, 7 or 8 weeks of gestation. Yes,
That's first trimester. So can you do? I don't think you can do the quadruple screening.
yes.
But you cannot. I think quadruple screening is second trimester. Second trimester. Um.
Quadruple screening usually done in the second trimester. Yes,
Yeah.
like
So
this
you
is the
cannot do that.
quadruple screening. What I have told you.
Yeah. So
It,
you cannot do that in first trimester.
yes, cannot do in the first trimester. You have to do it in the second trimester. So in the
Okay.
first trimester, like uh, lots of women have a concerning thing that my baby may have.
Yeah. So
So
what do
they
you?
actually,
Yeah.
the first thing you need to do, there is a question in the world maybe, that
Mhm.
cell-free fetal DNA, cell-free fetal
Self-free value.
DNA.
Wait, I have a thing for that.
Yeah,
Wait.
okay, find out.
I do have it. I have my little remembering notes. Yes, it's right
So
here. Yeah. Test for congenital anomalies in pregnant women.
yes, this is
Self,
for the fetal aneuploidy like Down syndrome,
yeah, self-free fetal DNA testing 9 to 10 weeks.
9 to 10
Chorionic,
weeks. Yes,
chorionic villus sampling. That's to check the karyotype. That's 10 to 13
10
weeks.
to 13 weeks. Yes,
And then amniocentesis for karyotype 2. That's 15 weeks.
yes,
And then the quadruple screening is for neural
16 weeks.
to 20, 15 to 22.
Okay.
Uh,
So
oh,
this is the thing you need to remember
that's
to
how I need
find
to
out
know.
the fetal aneuploidy.
Mm-hmm, mm-hmm, mm-hmm.
So you need to
Oh,
remember this flow chart. The
yeah.
quadruple screening usually in the second trimester,
I
like
think
15 to
I guess 15 up.
15 up. Okay, more than 15.
I just in my notes I only see I see 15 weeks gestation. I'm guessing it's 15 ups. 15 up.
Yes, it is. It should be 15 up.
Oh no,
So,
no, sorry. That's amniocentesis. Quadruped skinner is 15 to 22. Sorry, 15 to 22.
okay,
Amniocentesis it says 15 on 15 weeks only. That's what I see. Quadruped skinner 15 to 22.
okay. So to first for if you found a case with fetal aneuploidy, the first thing we need to do is the cell-free fetal DNA
Mm-hmm.
at 9 to 10 weeks. Then at 10 to 13 weeks, CVS like chorionic villus sampling, and
Mm-hmm.
at more than 15 weeks it is amniocentesis, and 15 to 22 weeks it is quadruple screen. Okay.
Quadruped skinner. Okay. So first trimester cell-free DNA and CVS. Second trimester amniocentesis and quadruple screen. Okay, got it. That's because I noted it, but I don't remember. I didn't remember why my tutor told me that it was important. I just didn't remember why. But now that you bringing it up, I'm like, wait, that's how.
That's why, like,
That's how it's important.
while we see the notes, we do not see the significance of that note. While we
Yes,
while we deal the question,
yes,
then we
yes,
start realizing that why it is important.
yes. Because I remember him telling me this is important, put it on your notes, but I don't remember seeing a question really about it. So I was like, oh, okay. But now that you brought it up, I'm like, wait, I remember writing this.
Okay,
Okay.
next.
But yeah, please keep bringing more of these facts.
Yes, yes.
But good.
Like discussion makes the thing. What can I say?
Yeah, it
This
makes me, for
it
me,
makes it helps to keep in memory.
remember, yes. Because there are a lot of things that I may not remember it from studying, but I remember you saying it here while and I'm like, yeah, I remember Omar saying that, so it's probably this, but I don't remember studying that.
Yes. Okay. 4 days after undergoing uncomplicated 4 days after 4 days after undergoing uncomplicated left total hip replacement, a hospitalized 75-year-old man has a 1 day history of progressive confusion. He began ambulating on post-operative day 1 and previously had been alert and fully oriented and cognitive intact. He has been receiving hydrocodone. He has been receiving hydrocodone for pain as needed. He has requested one dose. During the past 24 hours, he has hypertension. He has hypertension well controlled with atenolol. She has no other history of serious illness, takes no medication. On admission, the patient said he did not drink alcohol today. His brother says that the patient drinks 6 to 8 12 oz beers daily. The patient's temperature is 47 degrees Celsius, pulse is 90 per minute, respiration 14 per minute, blood pressure 130 by 80. Blood pressure 130 by 80. Physical examination shows lateral gaze pulsing. Other surgical incision is clean and dry. Non-erythematous neurological shows ataxia. On mental status, he is alert oriented. He identifies only one of the three options after 6 attempts. Okay.
So it is active timing plays complex role in neuronal physiology, including axon conduction, glucose utilization, and neurotransmitter synthesis. Thiamine deficiency results in neuronal damage. A mechanism that includes oxidative toxicity. Thiamine deficiency is most commonly encountered in the setting of alcohol use disorder because of poor nutritional intake, thiamine malabsorption, and impaired cellular utilization of thiamine. Thiamine deficiency causes two potential syndromes. Wernicke and Korsakoff. The toxic triad of Wernicke is encephalopathy, ataxia, and oculomotor issues as a result of neuronal damage of the cerebellum, midbrain, and pons. Common ocular manifestation is nystagmus horizontal dyspraxia caused by damage to abducens. Over time, thiamine deficiency can result in damage and atrophy of the mammillary bodies visible on MRI, which manifest as Wernicke. The symptoms of Wernicke are reversible but increase the risk of developing Korsakoff syndrome in chronic alcoholic user if not immediately treated with high dose parenteral thiamine. Korsakoff syndrome is a reversible condition that causes psychosis, anterograde, retrograde amnesia, and the consequent tendency to confabulate. This patient presents with classic findings of Wernicke and should be treated with thiamine. It's not lorazepam, it's benzo that is useful for treating alcohol withdrawal and delirium tremens. Delirium tremens can present with severe confusion and disorientation, fluctuations in consciousness, agitation, visual hallucination, autonomic instability. While it's important to consider delirium tremens in this patient with a history of significant daily alcohol use, the presence of lateral gaze vaccine ataxia makes monitor okay. Got it. Next.
The presence of lateral gaze palsy.
Oh, sorry, makes Wernicke more likely. Because I was wondering, because it looks like alcohol withdrawal, right?
Yes,
But because he used to drink every day, then he's been in the hospital for 4 days, so he couldn't drink, so he's having alcohol withdrawal. But 4 days for me should already be like the delirium tremens, but he doesn't have any tremors, and the
and and
delirium tremens also comes with autonomic instability. He doesn't have any instability. So I was like, wait, this doesn't look like alcohol withdrawal. So they're saying, yeah, he also has all the symptoms of Wernicke, like the nystagmus, the ataxia. So go more with Wernicke instead of
yes,
alcohol
yes,
withdrawal.
true.
I think that's what it.
A 42-year-old a 42-year-old man comes to the physician because of one day history of increasingly severe pain of his right knee associated with redness and swelling for the past 6 hours. She has had two episodes of pain in the right great toe over past 8 months and missed 2 weeks of work in construction. During each episode, he has been otherwise healthy. Examination of the right knee shows marked tenderness, swelling, and erythema. Lab findings are within the reference range except for a serum uric acid concentration 7.6. Examination of the synovial fluid aspirate shows uric acid crystal. Which of the following is the most appropriate initial pharmacotherapy? Ready?
Yeah. This patient is most likely presenting with gout flare because of the acute symptoms and increased serum uric acid concentration. Gout is acute monoarticular arthropathy resulting from intraarticular inflammatory reaction uh, to precipitating sodium urate crystal. Deposition of uric acid crystal may occur in the surrounding tissues, leading to development of tophi. Gout typically presents with a traumatic joint pain, erythema, and swelling. The most common joint involves first metatarsal, the big toe, but other joints like knee and elbows can happen. Increased intake of foods that are rich in purine, such as seafood and red meat, have been shown to increase the risk for gout flares, as they result in increased production of uric acid. Other causes of increased uric acid include diuretic hemolysis syndrome, alcohol consumption, obesity, arthrocentesis generally shows 10,000 to 50,000 leukocytes with a mixture of neutrophil and lymphocytes. Needle-like birefringent crystals are shown on microscopy. Treatment of an acute flare consists of NSAIDs such as naproxen or indomethacin as well as colchicine and steroids. The most appropriate initial pharmacotherapy here would be indomethacin. So NSAIDs, steroids, and colchicine.
Ready?
Okay.
Next. A 14 a 14-month-old girl is brought to the physician by her father because of 3-week history of cough. 1 month ago, she has the onset of nasal congestion and she 1 month ago she has had the onset of nasal congestion and runny nose. 2 days later, she was noted to have cough. The nasal congestion and the runny nose resolved spontaneously after 7 days. The cough has not improved. Her mother describes the cough as a dry smoker's cough. The patient has had similar symptoms twice during the past 6 months. Each episode resolved spontaneously after 2 weeks. At the age 3 months, she has bronchiolitis. She has eczema treated with topical hydrocortisone. She was born at term following an uncomplicated pregnancy and spontaneous vaginal delivery. She receives she sorry she received no other medications. Her mother has a childhood history of asthma and her father had seasonal allergies. The patient attends daycare 5 days weekly. She coughs intermittently. In the examination room, she is in the 20 percentile for length, 10 percentile for width. Her temperature is 37, blood pressure 100, lungs clear. Okay,
Hmm.
lots of things.
It has a lot of things. Mom, dad have allergic stuff. He's had bronchiolitis for the baby. And she also has eczema,
Atopic dermatitis, yes.
atopic dermatitis. So probably like asthma. I don't know. Doesn't look like it. Not system. It's not IgA. Is it pneumonitis? What was pneumonitis again? I forgot. Fine.
In
Okay. I just give up today. This is just a bird. I don't know what's happening today.
You are right.
Okay, I'm right.
Don't give up.
I don't. I don't even know why I'm right. I'm just. I just get. I don't even. Oh my goodness. Asthma particularly caused by
Uh, wa- One of the block will come in this pattern.
remember when we started this MBA? It, the first block looked so, so
Yes,
nice.
I know.
I'm
I,
like,
I have no problem if it came at the seventh or eighth block, isn't it?
8 block. You see? Yeah,
Yes.
yeah.
Then our energy is gone. If that block is also gone, then nothing to do. But if it comes in the first block, I don't think that it is very hard to carry them.
Yeah. I think you need a good break. Like if this is your first
You
block,
can't take a good break after first block. That would be an injustice for all the blocks.
no, if you have questions like this for first, I think you need a good break just to come back and be like, it's fine, it's fine, it's just one block. Just hey, you know, 'cause Jesus, I don't know what is happening today. I'm just
In our country, there is only one center. Okay, and
oh,
in that center, from going inside and getting out, you need at least uh, fi 5 minutes. So your 5 minutes is waste while
mm,
checking.
I get what you say. I get what you say.
And
No,
there are lots of other exams too, like
yes, yes, yes. There are
yes.
people that are
So
taking other exams.
and in that exam center there is only one washroom. You got my point. What I'm
I
talking
get
about?
what I
I'm
get.
talking about reality. I'm not
No,
talking
I
about here
get.
and there.
Then yeah, yeah. This is not an option for yeah. I get what
So
you
if
say.
somebody is inside, then another 5 minutes is wasted, or another 10 minutes may be wasted. You can't knock the door, isn't it?
Yeah, yeah, yeah.
And you can't get out from
Yeah,
that center.
I get what you're saying. Yeah. Yeah, you don't have that option. Here in the island where I'm in Hawaii, the island,
Yes.
we only have one center, but the two times that I went, it wasn't full. Like I don't feel like a lot of people take exam in that center because it wasn't full. But then it's a small island too, so it's not, I don't there are not that many people also. So I think that's also, yeah. Because, wow,
No, like in the if exam center is empty, that is very good.
that is
Like
good. Yeah,
if exam center is filled with people, that is very problematic.
yeah, that's true. That's true. Because even during the exam, people will be making weird noise. I think it was the second time I took it. Somebody like sing. They were singing while they were taking their exam. And, you know, I could I could hear them. You know what I was taking. I don't know. I was like, oh my god. And then there was construction happening on the
Okay,
on the street.
n- in that center, that is not a problem. But the only problem is the air condition, which becomes so like what can I say? You can't turn off the air conditioner.
But I think that's it. Like it gets really cold.
Yes,
Yeah, I think that's everywhere. Because that, yeah.
like I need to take a jacket on
Yeah.
that this hot sunny day.
Yeah, no, I think they do it. I think that's in every center for all the standardized.
Why is that?
I think I think they're doing it. I I don't know. I think it's
Is it an exam too? Like they are checking your
no.
body's temperature?
I think it's a bacterial thing. Like I don't know. They think it kills the bacteria. I don't know. I don't know. But it's every
We,
standardized exam.
like
Even
we are not
they
like
do it.
I am not accustomed to take the AC for such a long time.
Oh, okay, yeah. I mean, I don't like it too, but I think it's just all the testing centers that I've been to. They always like that. They always put it the ACI. So I just assume it's, for infect bacterial. They don't want to. Don't know. So yeah.
Along with bacteria, our brain cells also die.
Also die because it. No, you should have seen me the time that I went and took the step. Like I was wearing like two jackets and a hat and all that. Yeah, yeah. It's always cold. But then as you start doing the exam, believe me, you get hot. Because once the questions start getting really, really tough, you start getting hot and you remove one jacket. Believe me, you're gonna see. Like,
Okay,
yeah.
let's see what happens.
Asthma, particularly cough variant asthma, is the most likely diagnosis for the patient. Asthma often presents with episodic wheezing, shortness of breath, with or without cough. But it can also present with just a cough. Patients should be assessed for other atopic symptoms like allergy, rhinitis, eczema, as these conditions commonly occur together with asthma. Other causes of chronic cough include GERD and rhinosinusitis. Patients in whom asthma is suspected should undergo spirometry with measurement of FEV1 and FTC. As asthma is a reversible and it's episodic condition, spirometry is frequently normal, and unless the patient is exhibiting symptoms at the time of the spirometry. Therefore, most patients undergo metacholine challenge test. Metacholine challenge test is a potent stimulator of bronchoconstriction. And as asthma is defined by airway hyperactivity, patients with asthma tend to experience bronchospasm at lower doses. An improvement in FEV1 by at least 12% with bronchodilator is diagnostic of asthma. Treatment depends on the severity but may include short-acting bronchodilators and inhaled steroids. I don't know what is happening here. In cannot move it. In overall, diagnosis of asthma are not made prior to 2 to 3 years of age. I'm guessing you cannot make diagnosis prior to 2 or 3 years of age. Infants cough and wheeze for many reasons, and knowing whether primary airway hyperactivity is present is challenging, as infants are generally not able to perform pulmonary function tests. In the infant group, if symptoms of bronchoreactivity are present, physicians may treat the symptoms in the same manner as asthma if a consistent clinical response is detected. Okay. Is not chronic bronchitis refers to long-term inflammation of the bronchi, as is commonly seen in patients that smoke. Is defined as presence of productive cough. You need to remember that. Productive cough for 3 months for at least 2 consecutive years in patients who do not have another cause of cough. This will be rare in a child. Okay. And it's not hypersensitive pneumonitis can present in acute, subacute, chronic form, with acute form characterized by shortness of breath, cough, and systemic symptoms such as fever, chills, headache, and rash following exposure to environmental um, irritant. Hypersensitivity pneumonitis will resolve after the irritant is removed. Okay. Next.
A previously healthy 24-year-old nurse is brought to the emergency department because of weakness of the lower extremity for 24 hours. She takes no medication and temperature is 37 degrees Celsius, pulse 30 per minute, blood pressure 112/78, muscle strength 4/5, upper and lower extremities. Lab shows sodium 134, chloride 94, potassium 2.4, bicarbonate 34, magnesium 2.4, urea nitrogen 14, glucose 118, urine sodium 46, urine potassium 6. Which of the following is the most likely cause of these patients' hypokalemia?
Sodium is low, chloride is bit low, bicarb is high, glucose normal, urea and urea. Urea is normal. Magnesium is 2.4. Magnesium is high. Okay. They're asking for the cause of the hypokalemia. Doesn't take any medications. She looks like me. Sodium is low, and potassium is low, and chloride is low. So everything is kind of low. Then the bica, which is high. Aldosterone secreting tumor. Aldosterone sodium will be high. Juxtaglomerular cell juxtaglomer. What was the juxtaglomerular? I forgot. Ah, no, it will be high too. So repetitous diuretic use. Yeah, it's between D and E. Let's see. In diuresis, yes, yeah, it's this one. Okay. Okay, ready?
Yes.
This patient's hypokalemia is likely caused by surreptitious diuretic use and factitious disorder. In factitious disorder, patient consistently produce symptoms for primary gain. Primary gain is the motivation to be careful, which constitutes an unconscious motivation for the patient's conscious production of symptoms. Early losses, neglect, or abuse may disrupt patient identity and relationships, and adopting the sick role may represent an alternate attempt to cope with stress and stabilize whatever. In patients with hyponatremia, hypokalemia, normal kidney function will lead to decreased urinary excretion of sodium and potassium. These patients' repeated use of diuretics led to low serum sodium and potassium concentration with abnormally increased concentration of urine sodium and potassium. Treatment of factitious disorder includes regular follow-up with one physician who oversees management, as opposed to symptom trigger appointments and possible psychotherapy. Next.
A 47-year-old woman, 47-year-old man comes to the office because of 6 month history of non-painful, non-itchy lesion over the left forearm. 3 years 3 years ago, he has underwent a renal transplant for chronic renal failure secondary to IgA nephropathy. His only medication is tacrolimus. Vital signs are within normal limit. A photograph of the lesion is shown. The remainder of the examination shows no abnormal. Which of the following is the most likely diagnosis?
Ready?
Yes,
So squamous cell. I always forget what actinic keratosis look like. So it's a squamous cell carcinoma, second most common skin cancer after BCC. SCC is the skin of the skin is related to UV damage, chronic inflammation, additional risk factor for the development of SCC include immunosuppression, especially in patients with a history of solid organ transplantation. SCC usually occurs at site of chronic sun exposure, including the face, ears, neck, distal extremity. So SCC typically presents as rough plaque or nodule with focal erosion or ulceration and overlying hyperkeratotic scale. Pathology shows parakeratosis, loss of the epidermal granular layer, full thickness epidermal atypia, keratin pearls, and invasion into the dermis. SCC is treated with excision or base therapy, including most microsurgery and electrodesiccation and curable. Location of the lesion on sun-exposed skin, chronicity of the lesion, and the patient immunosuppression status are suggestive of ACC. Antikeratosis like SCC are related to UV damage and found on exposed sites, including the face, ear, neck, and distal stem. Antikeratosis typically presents an ill-defined rough scaly patch. Huh. Antikeratosis represent partial thickness atypia or epidermal keratinocytes and may progress to SCC. Antikeratosis are treated with cryotherapy and topical 5-FU. Although antikeratosis may be a precursor to SCC given the chronicity of the lesion size and the patient history of immunosuppression. This is SCC. Let's see what actinic keratosis look like. Actinic keratosis.
in here, what is the risk factor? Like renal transplant.
Yeah, the transplant that he had. I guess they cannot really give actinic keratosis and SCC the same because they look kind of alike. What is the difference between?
Like basal cell carcinoma.
No, it looks like S- actinic keratosis and SCC. What we did for me, they look alike on the pictures.
Yes, truly. They are look very similar. They look very similar.
I mean, the basal cell, they have the
Yes.
telangiectasia, so that one I can figure it out. But
And
I just
melanoma is easy also.
melanoma is easy also. But here on this picture, I'm like, how
In
do
this
you?
picture, initially I thought there is like when we fall somewhere, there is such kind of
Ah,
picture.
like, no. I knew it was between actinic and squamous cell, but I was like, I don't remember what actinic looked like at this point. Okay.
I answered actinic keratosis because it looks like actinic, but as like I think that the immunosuppression is one of the key factor
The one
in
of the
the
key. Okay. Okay.
like
I would just,
in the SCC like burn immunosuppression in most of the question burn immunosuppression UV radiation these are the features in SCC.
okay. I'll just remember actinic and that also looks like this, like something like this, just in case I see it somewhere else. Okay, next.
Okay. A 62-year-old, a, six, a 62-year-old man with COPD comes to the physician because of 1 month history of leg swelling and progressive shortness of breath. 1 month history of leg swelling and progressive shortness of breath. He has not had fever or cough. He smoked 1 pack of cigarettes. He smoked 1 and 1.5 pack of cigarettes daily for 45 years, but quit 1 year ago. His medications are theophylline and albuterol and ipratropium inhaler. His temperature is 36.7 degrees Celsius, pulse 96 per minute, respiration 22 per minute, blood pressure 150 by 76. Examination shows jugular venous distension 10 cm above the sternal angle. Breath sounds are markedly decreased throughout the lung field. Cardiac examination show decreased heart sound with no murmurs, gallops or rubs. The liver edge is palpated 3 cm below the right costal margin. There is 2 plus pitting edema to the knees. His FEV1 is 1.05 ml. Arterial blood gas analysis of the room air shows pH 7.2, PCO2 48, PO2 45, and bicarbonate is 30. X-ray shows a hyperinflated lung with apical bulla. Which of the following is the most appropriate next? Is it respiratory alkalosis?
The pH is non. It's normal. I mean, I guess it goes more into the, but it's still normal. I guess it got more into alkalosis than acid, but it's still normal. I guess it would be like metabolic alkalosis.
Oxygen is low, isn't it?
Oxygen is low. So I'm thinking, I don't remember what were the limits for home oxygen therapy. I forgot. I think it was 88 or 50.
Domiciliary oxygen therapy for COPD patient.
Yeah, I forgot what it was. But let me see, mechanical ventilation. No, yeah. Respirations are fine. It doesn't make long volume reduction.
5585 or 5588.
55, 85. Okay, so, but why are we going to give him oxygen? His lungs are big or not?
He has JVT, jugular venous distension. So, is it failure?
What
Um,
failure of what?
like due to a lung heart failure? Because the features are like failure.
Okay, but if it's heart failure, what? Okay, you think like mechanical ventilation?
No, no,
What?
mechanical ventilation. Why mechanical ventilation? Patient is stable. We need to increase his oxygen level by giving oxygen, isn't it?
But his lungs are hyperinflated. You're gonna add more air to it? Okay, I guess. Okay, fine, fine. Okay,
You want
okay.
what do you want to do?
I don't know. Fine. They just I don't know. Okay, none of
This
it. The
is
other makes sense.
you
Okay,
want to make the rupture of the bulla. Okay,
fine.
let's say
No, no. Non-volume reduction operation. No, you
it
cannot
is
go.
lung volume surgery. It is not.
It's not.
It
Yeah.
yes, it is not that.
Okay, fine. Let's do. Let's give oxygen. Fine, fine. Okay. This, yeah, it's oxygen. You say it was 58, 55 to 88. Oh,
Can you remember that there is a like in COPD patient in LTOT, like long-term oxygen therapy, there is a thing like that.
What I don't understand what you're saying.
Like, can do you remember the long-term oxygen therapy for
Mhm.
improving mortality in case of COPD patient to prevent the failure, right
Yeah,
ventricular failure?
yeah,
It is like if SaO2 law, if
yeah,
SaO2 is less than 88 or PaO2 is less than 55 at rest or
yeah,
during sleep,
yeah. I
and
remember.
5588 and 5989, like if SaO2 is less than 89 and PaO2 is less than 59, our PaO2 is less than both 59 and 55, isn't it? And there
Hmm.
is evidence of like pulmonary hypertension, like core pulmonary, then you need to give long-term oxygen therapy. This patient has like features of core pulmonary. This one, yes, this one. So resting is 5588. Like PO2 is less than 55 and SO2 is less than 88. And second one is 5989. PO2 is less than 59 and SO2 is less than 89. In both cases, in our PO2 is low in this patient. In this patient, PO2 is 45, so it is low. So it can fall any of the categories. And in our patient, like there is JVT distension, features of right heart failure.
Yeah. How you remember this? The 58. Yeah, I remember how you
50, 5588 and 5989, like 99, make
remember.
the sound as if it is what can I say? It is a
Nine,
as it is a song or it is like that. I try to make something like recently I made it like that, like dissection for hypertension, dissection for hypertension, aortic
okay.
dissection for hypertension. But
Yeah.
AAA, like abdominal aortic aneurysm, is smoking. Like if
Mhm.
you in the cartoon you have said, sorry, you have seen that the smoke is floats in the air and it looks like AAA. Like you think like you are smoking and your smoke is floating in the air like a, and the main thing is that the risk factor for abdominal aortic aneurysm is smoking and the risk factor for aortic dissection is hypertension. These two is very crucial in the exam.
Yeah, they are. If they are,
Like
actually.
I know it, I know, but in the exam I will get confused.
No, I don't think I'll forget the dissection hypertension.
Yes, so make this thing, make the sound looks like that it is like a rhyme or like that. Okay, I
Then
should,
like
if I
pulmonary
can't
has
do anything, then I will try to write a book regarding this type of thing.
listen. I feel like at this point, if we are able to finish this journey and become doctors, we should definitely write the book. Or write a movie or something, make a movie, something, because Jesus, this is whew, Jesus. Anyway, pulmonary hypertension can be primary, like a genetic mutation causing smooth muscle hypertrophy and increased pulmonary vascular resistance, or secondary, like OSA, COPD, chronic venous thromboembolic disease, pulmonary fibrosis, heart failure. It presents with signs of right-sided heart failure, including edema, JVD, hepatic congestion. Cardiac exam typically discloses a precordial heat delay or loud pulmonic valve closure. Tricuspid or pulmonary insufficiency due to chronic hypertrophy of the right side of the heart. Treatment depends on the cause of pulmonary hypertension. In this case, the cause is more likely secondary to progression and severity of patient COPD. Because of this, therapy should be focused on improving oxygen status. Given the PO2 45, supplemental oxygen should reduce the pulmonary vascular constriction, contributing to pulmonary hypertension. Also, that's why he has pulmonary hypertension.
Okay, next. A 21-year-old man is brought to the emergency department because of 2-hour history of multiple muscle spasm of the face and muscle spasm of the face and the neck. His eyes appear to be rolling up inside his head. Um, he began treatment with haloperidol 26 hours ago. The paranoid ideation. His temperature is 37, pulse is 96 per minute, respiration is 18 per minute, blood pressure is 130 by 82 millimeter of mercury. He is fully oriented and cognitively intact. But he is adamant that he has been poisoned. Which of the following is the most appropriate to add his medication regimen?
Ready?
Yes,
It is benztropine. He has acute dystonia, involuntary painful muscle spasms that occur most frequently respond to D2 antagonists such as antipsychotic like haloperidol. Underlying pathophysiology is an imbalance in dopamine and cholinergic pathways in the basal ganglia, increased cholinergic activity and decreased dopaminergic activity. Acute dystonic reaction are treated with diphenhydramine and benztropine, which are both anticholinergic medication that work to restore the proper balance in the dopaminergic cholinergic pathway. Common presentation include torticollis, streptococcus, opisthotonus, opulop. Patients rarely present with laryngospasm and stridor. These factors for development include male sex, young age, recent cocaine use, and history of acute dystonic reaction. Okay.
next. A 60 a 60-year-old man with a stage 4 chronic kidney disease comes to the patient for follow-up examination. He also has type 2 diabetic hypertension, a medications are insulin, lisinopril, furosemide, amlodipine, aspirin. Vital signs are temperature 37, pulse 80 per minute, respiration 15 per minute, blood pressure 145 by 85. Cardiopulmonary examination discloses no abnormality. There is there is one plus lower extremity edema. Lab studies show serum intake parathyroid hormone concentration 250 picogram per ml. Measurement of additional serum. Lab studies is most likely to show which of the following.
Ready?
Yes,
There is increased phosphorus, decreased calcium, and decreased calcium. One of the complications of long-term diabetes is the kidney nephropathy. The kidney nephropathy, chronic process that occurs following non-enzymatic glycosylation of the glomerular basement membrane and efferent arteriole, characteristically demonstrating heme Wilson lesions on light microscopy. It progresses over time in patients with diabetes, initially beginning at microalbuminuria, which subsequently leads to macroalbuminuria and then end-stage kidney disease. Secondary hyperparathyroidism is commonly as a result of chronic hypocalcemia in the setting of end-stage renal disease. Hypocalcemia in end-stage renal disease occurs as a result of decreased native kidney function, decreased native kidney production of calcitriol, which is the active vitamin D, which leads to decreased systemic absorption of calcium and increased concentration of phosphate because of retention by the kidney. Increased phosphate also complexes with calcium in the serum, decreasing the total serum calcium concentration. In patients with CKD, 1-alpha hydroxylase activity is decreased and thus calcitriol is also decreased. In turn, hypocalcemia is sensed by the normal parathyroid gland, which increases synthesis of parathyroid hormone. To attempt to normalize the calcium concentration to osteolysis, conversion of vitamin D and GI absorption. Next.
Okay, next. A 7-year-old boy is brought to the A 7-year-old boy is brought to the office by his mother for an initial well child visit to establish care. The patient's family recently immigrated from Eastern Europe. The mother is concerned about her behavior at son's behavior at home and in school. He has been easily distracted and has difficulty completing his chores at home, has been fidgety during classes, and often disrupts others by talking out of turn. His mother says that as an infant, he underwent surgical correction of the cleft palate and heart defect, but she does not have medical records with her today. The patient is 5th percentile height and weight. Examination shows an elongated face and narrow superficial low set ears, broad nasal bridge, micrognathia, and down, downward turned mouth and small teeth. Which of the following is more likely abnormal findings?
Let's see how.
Sorry, what is your diagnosis?
I don't know. Is it the George?
Yes,
Okay, okay. I was like, what does he have? The downward mouth and all this. Okay, got it. Ready?
yes. If you
Read
know
them
the
back.
diagnosis, try to match your diagnosis with the features. Then you can save your time. Like you know DJs, but you are actually looking for excluding the options, isn't it?
No, I didn't know. I didn't even know I was guessing. I couldn't know the diagnosis. That's why I started. And I couldn't exclude here. So that's
Because
why I asked
if
you.
you want to exclude from here, you will
Here
be in a
I
deep
cannot
trouble.
exclude. Yeah, here I cannot exclude. That's why I asked, like, what the hell is the diagnosis? Because here you cannot exclude.
Yes.
Okay, okay. Thymic parathyroid dysplasia. Thymic parathyroid dysplasia, known as Joe syndrome, is a disorder caused by microdeletion of 22q11 chromosome, which results in abnormal development of the third and fourth pharyngeal pulses. It presents early in childhood with thymic hypoplasia and impaired immunity. Okay. Conotroncal cardiac defects like PST, bronchosaturasis, hypocalcemia caused by parathyroid hypoplasia, and craniofacial abnormalities such as loss of ears, hypertelorism, micrognathia, I think that's small eyes, micrognathia, I don't remember, and cleft lip and palate. It's also associated with developmental delay, ADHD, and autism. Severe hypocalcemia can lead to seizure as well as laryngospasm, bronchospasm, emesis. Results of lab studies will show low calcium concentration and possible leukopenia. Chest X-ray may show absence of thymic shadow as well as narrow mediastinum and right-sided aortic arch. Right-sided, okay, as suggested by the patient's reported history of heart defect. Further evaluation typically includes echo and ultrasound of the kidney. Treatment is supportive and calcium repletion is critical in most cases of seizures. Wait, what do we check the kidneys again?
Sorry.
What is this? It says that. Evaluation includes echo and ultrasound of kidneys. Why
In
kidneys?
in DiGeorge syndrome, there may be renal agenesis.
Renal agenesis. Okay.
Yes, if you see no kidney, then
Mm.
in the characteristic feature for DiGeorge, like there may be a ptosis, epicanthic folds, there may be white space, wide set eyes, high nasal bridges, cleft palate, there may be hearing loss, and cardiac defect is important. Very important is cardiac defect like VSD, TOF can happen, truncus arteriosus. There may be thymic aplasia, and there may be renal agenesis. There may be anal atresia also. And on lab, you may found hypocalcemia. Okay, and there are some psychiatric feature can happen in case of DiGeorge, like ADHD, schizophrenia can happen.
Get it?
Lots of information. I know it.
Yeah. The clinical features, the face and all these things. That's where I got confused. So that was like,
Like
wait,
remember the catch 22 in the
yeah, yeah.
yes, conotruncal abnormality, abnormal faces, thymic aplasia, then calcemia, hypocalcemia. There may be cleft palate and 22q. Okay. A 4-year-old boy is brought to the emergency department. Brought to the emergency department 30 minutes after the sudden onset shortness of breath and wheezing at a birthday party. Witness report that he was acting normally until he was noted to be in distress. They did not see him choke on anything. He has no history of serious illness and receives no medication. His temperature is 37 degrees Celsius, pulse 100 per minute, respiration 24 per minute, blood pressure 90 by 60, pulse oximeter on room air, so oxygen saturation is 95%. Examination shows decrease of breath sounds over the left hemithorax. Inspiratory and expiratory chest X-rays are shown. Which of the following is the most likely diagnosis? Shortness of breath.
What shortness of breath?
Just within 30 minutes, there is shortness of breath. And in the X-ray initially, the right, it looks like foreign body aspiration, isn't it? Look at the right lung.
The right will
In
be this.
yes,
Wait, the right will be this, right?
yes. The inspiratory phlegm, the
I mean, it's a baby, so it's not gonna be pneumothorax, right? Doesn't
yes,
make doesn't make that much sense.
and maybe he eat something.
Wait, yeah, I probably put something. Nobody saw him, but he put something in his mouth.
Yes,
Okay,
yes, we are in the right track.
yeah, okay, right. The person chose pneumothorax, the person that was doing this. Acute onset difficulty breathing and wheezing raises suspicion for as foreign body aspiration. Foreign body aspiration can cause obstruction of the airway, leading to impaired oxygenation and ventilation. Young children are at increased risk for foreign body aspiration because of their ability to stand and mobilize independently, ability to grasp and put small objects into their mouth, and in an immature swallowing mechanism. Foreign body can be located anywhere in the airway between the larynx and the bronchi. Children can present with severe respiratory distress, cyanosis, stridor, or may have less severe presentation with airway obstruction, presenting with cough, tachypnea, decreased air entry on auscultation, and wheezing. Chest X-ray can show hyperinflation of the lung, which is caused by air trapping and partial airway obstruction in which air is able to pass via inspiration but not exhalation. Foreign bodies are typically in the right lung because of the more vertical anatomy position of the right main bronchus. Management of foreign body inspiration involves flexible or rigid bronchoscopy to remove the object. Object removal is necessary as foreign bodies can be complicated by airway inflammation and infection. Wait, let me read that one. Pneumothorax presents with shortness of breath, chest pain, and tachypnea. Yeah, with decreased breath sounds are hyperresonant to percussion and affected side. Pneumothorax will be uncommon in a patient that is this young unless there is a history of trauma preceding the incident. Spontaneous pneumothorax can be seen commonly in tall male teenagers with low BMI. The X-ray shown. Okay. Oh wait, the X-ray shows reflects it hyperinflation from obstruction during exhalation, not an absence of lumbar disc. Okay. Next.
Yes. A hospitalized 59-year-old man has undergone three unsuccessful attempts at endoscopic sclerotherapy for his visual paresis. During the past 4 days on admission, he had a 1 week history of recurrent upper GI bleeding. He has necrotizing pancreatitis, thrombosis, type 2 diabetes, mellitus, and hypertension. His medications are insulin, hydrochlorothiazide, DC, no pancreatitis. He has history of alcohol use disorder but has not consumed alcohol during the past 8 years. He has no history of psychiatric illness. He is inmate in federal prison. He is inmate in federal prison and has 18 years remaining of the sentence. He asks that no other efforts to control the bleeding to be undertaken. His brother, who has not visited the patient in 6 years, says that this patient is that this is the patient's way of committing suicide. The brother insists that efforts to extend the patient's life to be continued. The patient appears catatonic but alert. His pulse is 104 per minute. Respirations are 18 per minute. Blood pressure 88 by 68. Pulse oximetry 4 liter per minute. Oxygen by nasal conversion. Oxygen saturation 94%. Physical examination shows scattered ecchymosis and petechiae over the upper extremity. On mental status examination, he provides an accurate account. He provides an accurate account of his current condition and the probable outcome, including death. If he continues to bleed, he says he is down, but then says he means tired. He reports no suicidal ideation. Which of the following is the most appropriate next step in the action? Okay.
A. Abide patient request. According to ethical principle autonomy, a capacitated patient wishes about end of life care should be respected. There are several methods to determine a patient wishes, including communication with the patient directly if the patient has capacity, or reviewing advance directives that have power of attorney, consulting with close family members. If these resources of information conflict, a capacitated patient wishes to persist the other resources. To meet criteria for decision of capacity, patient must express a consistent choice, demonstrate understanding of the risks and benefits of the choice, demonstrate an appreciation of the significance of the choice for their personal circumstance, and illustrate an ability to reason through the option. Given the consent for suicidality, the physician has duty to evaluate the patient for depression and suicidality to ensure that a psych disorder is not interfering with the patient's decision capacity. Not all patients with psych disorder lack decisional capacity, but some patients with depression have inaccuracy, bleak outlook in the future. However, this patient denies depressed mood and suicidality and demonstrates an accurate understanding and apprehension of his features. So he appears to possess decisional capacity. Therefore, his wishes to withdraw care should be respected. Next.
Yes, a 12-year-old girl is brought to the emergency department by her parents because of 2 hour history of severe weakness involving the right side of her face. The weakness has been present since the patient awake from sleep. She is now drooling from the right side of her mouth. She has had upper respiratory illness for the past 3 days with symptoms of nasal congestion, cough, muffling of sound, and pain in her right ear. Medical history is otherwise unremarkable. She has been taking acetaminophen as needed for the ear pain vital signs and within normal. The patient is awake and alert. Her speech is desultory. Her speech is desultory. The right side of the face is severely weakened with inability to sustain high posture against resistance the remainder of the examination. The remainder of the physical examination discloses no abnormality. Which of the following is the most likely nature or evaluation of our condition if left untreated? Ready?
Does it improve over months or over days? Improve with normalization. Oh no, whatever. Yeah, improve over several months. In Bell's palsy refers to facial nerve palsy that leads to unilateral facial paralysis. It's most commonly caused by viral mediated inflammation or immune reaction in the setting of herpes simplex or herpes zoster, although it can also be idiopathic or caused by other viral infection. It presents acutely with unilateral facial paralysis that includes forehead consistent with lower motor neuron pathologic involvement. Can also be associated with loss of taste on the anterior two-thirds of the tongue and decreased lacrimation. Symptoms typically peak around like 3 weeks after onset with slow recovery beginning within 6 months. Diagnosis is most commonly based on clinical symptoms, but electrodiagnostic tests such as EMG and imaging of the face and head can be used if the diagnosis is unclear. Initial treatment is oral steroids such as prednisone and antiviral therapies. Improvement with normalization in 2 3 days does not accurately describe first-event palsy. In partial nerve palsy that results as a complication of otitis media, recovery may take days rather than months. However, this patient shows no sign of otitis media. Okay. Next.
A 56-year-old woman comes to the clinic for examination prior to undergoing dental procedure. She will be visiting her dentist frequently for multiple procedures to have braces placed on her teeth. Because of severe temporomandibular joint, she is concerned about her risk of infection. She has mitral valvulus and intermittent palpitations. She also has hypertension and osteopenia. Her only medication is atenolol. Her blood pressure is 110 by 60 millimeter of mercury. Examination shows no abnormal antibiotic prophylaxis is indicated for this patient. Okay, ready?
Mm, no prophylaxis needed. Endocarditis prophylaxis is recommended for patients with high-risk cardiac features and the procedures that put in mind. Increased risk for developing of bacterial endocarditis. These cardiac features include prosthetic heart valves, prior infective endocarditis, or repair congenital congenital cyanotic heart disease, or repair disease with residual shunts or valvular regurgitation near prosthetic material. Residual shunts. Repair congenital defects with a catheter-based intervention for the first 6 months after the procedure, and valvular regurgitation in a heart transplant recipient. High-risk procedures include dental procedure with gingival manipulation or perforation of the oral mucosa, a respiratory tract procedure in which the mucosa is violated, procedure of infected soft tissue, and cardiac surgeries with prosthetic material. Amoxicillin is the most common prescribed antibiotic for bacterial endocarditis bronchitis and is given in a single dose, 2 grams, 30 minutes prior to procedure. This patient does not present with high-risk cardiac features, so there is no indication for endocardial prophylaxis. Next.
A 62-year-old man comes to the physician for a preoperative evaluation before undergoing elective cataract removal. He has 3 months history of he has 3 month history of progressive mild shortness of breath with exhaustion. He takes no medication. Blood pressure 150 by 9. Eye examination shows no other abnormality. Hematocrit 26, mean CP 75, glucose at 6,000, PT 11, glucose, serum glucose 89, creating 1.6, 142. Which of the following is most likely to prevent the hematological?
Wait. Therapy, promise of length. What does he have?
His platelet count is high.
Okay. Platelet count.
Thrombocytosis.
Thrombocytosis, anemia, alpos is high, which is
Creatinine is also high.
the thrombocytosis, which creates the thrombus. It explodes the anemia, alpos. That makes sense. Okay. And then creatinine is high and AST is high. Oh, let me see if I can remove something. Annual blood pressure measurement. Avoidance of alcohol. He doesn't drink that much. Avoidance of radiation exposure. That makes sense. Colorectal cancer screening. Colorectal cancer. No, I think it starts at 60. Some. Oh no, it starts at 45. That it doesn't make sense. Measurement of keto, no. Thyroid test every 2 years. Thyroid, no. Daily multiple, no. Subcutaneous erythropoiesis therapy. And between, what does he even have? I'm like, wait.
Think about in this way, like he has low hemoglobin and MCV is also low. Like any older patient,
MCV is
remove
not low.
remove everything. Just 2 points. You found a patient with low MCV and
MCV is not low.
uh, it is microcytic pattern. 80 to 100 is normal.
Oh, it's microcytic. Okay, never mind. I thought, wait. And I looked at it and I, okay, fine. So he has some kind of cancer. So what does that have to do with the
They
plate?
they actually distract us by this
Oh,
field.
Okay, okay. Somebody, what does that have to do with later? Okay. Colorectal cancer screening, GI blood loss. Ah, yeah, we need to stop to for today. GI blood loss. Yeah, today is just now. I need to reset. Yeah, GI blood loss resulting in chronic iron deficiency more likely explain this patient progressive shortness of breath. And that findings of microcytic anemia. Anemia can be an indicator of colorectal cancer. The USPSC recommends routine colorectal cancer screening for all patients. At average rate of colon cancer, 45 to 75 years old. Colorectal cancer is common in early detection. Yeah, a variety of tests may be used for colorectal cancer, with colonoscopy remain the gold standard screening, as it allows for visualization and excision of polyp through the length of the colon. Other direct visualization tests such as other testing strategy is stool-based tests, FOTB, fecal immune chemical test, CT colonography. Patient with unexplained iron deficiency anemia, colonoscopy is the need to rule out. Yeah.